In this video, we will be discussing the pathogenesis, or the causes and mechanisms, of exercise-associated hyponatremia. It is necessary to first define a number of terms. Specifically, hypotonic refers to a solution containing a lower concentration of dissolved substances than the blood, particularly sodium in this context. Serum is the fluid component of blood similar to plasma. Osmolality is the effective concentration of dissolved solutes in the blood, with particular reference to serum sodium concentration. Hypovolemia refers to a reduction in total body water volume. Metabolic production of water is the generation of water from burning carbohydrates to produce energy. AVP, or arginine vasopressin, causes the kidneys to retain water. This is also known as ADH, or antidiuretic hormone. ANP and BNP are atrial and brain natriuretic peptides, which cause excretion of sodium in the kidneys. GFR is the glomerular filtration rate, which refers to the rate of fluid filtration through the kidney. This is how water and sodium remain in balance under normal circumstances. Intake of water and sodium equal losses through the kidneys and through sweat. This is controlled by a number of hormones and processes including AVP, renal blood flow, and GFR. Now, during exercise, sweat losses increase, metabolic production of water increases, and excretion of water from the kidneys decreases due to reduced blood flow and GFR. Since sweat is less concentrated than blood, this will normally shift the serum sodium concentration up, assuming no additional intake of food or fluid. This increase in osmolality is sensed by the hypothalamus, and AVP is released from the posterior pituitary to fix this imbalance. AVP acts by increasing water retention in the kidneys through water channels known as aquaporins. If an athlete sweats enough, they will become thirsty due to decreased blood volume. They will then increase their fluid intake to correct the hypovolemia if possible. Often, this consists of water or sports drinks where the sodium concentration is lower than that of the blood. This fluid intake corrects the volume loss but can decrease the osmolality of the blood. Over the short term, as in shorter races, this is fine. Volume and osmolality are within normal ranges, and the athlete would not notice any symptomatic changes. However, during a longer race of many hours to days, the replacement of sweat losses with water would slowly dilute the blood, lowering the sodium concentration. Fortunately, the levels of AVP will decrease and allow larger amounts of water into the urine and perhaps normalize the situation. If the athlete were to continue drinking large amounts of water or dilute fluids, then hyponatremia can develop. The main factor in the pathogenesis of hyponatremia is the consumption of large volumes of water beyond thirst. This can happen, for example, if a racer is following a drinking schedule. The quantity of water simply cannot be eliminated by the kidneys, which are limited to excretion of approximately 1 liter of water per hour, even with minimized AVP levels. This leads to dilution of the blood and a decrease in the serum sodium concentration. A contributing factor to the development of hyponatremia is that some individuals will not fully suppress AVP. Thus, they cannot dilute their urine fully and will have reduced excretion of water and increased sodium losses through their urine. AVP may be inappropriately elevated due simply to exercise, heat exposure, inflammation, or if the athlete is still significantly hypovolemic. However, non-suppressed AVP alone is not sufficient to develop hyponatremia while exercising. The overconsumption of fluid is necessary as well. Additional factors contributing to hyponatremia may be inappropriately elevated ANP and BNP levels, leading to excretion of sodium from the kidneys, as well as a compromised ability to mobilize sodium stored in the bones. So far, we have discussed development of hyponatremia in the context of ongoing exercise, yet there is another important mechanism post-exercise. Let's assume an athlete finishes their race with a normal blood volume and osmolality, but they drank a large volume of water during the race. It is possible that due to reduced gastrointestinal blood flow, this fluid was not absorbed and is still in the GI tract. When the athlete stops exercising and absorption of the GI tract resumes, this bolus of water will be absorbed and will significantly dilute the blood, causing hyponatremia. For this reason, exercise-associated hyponatremia is defined as a blood sodium concentration lower than 135 millimole per liter during or up to 24 hours following an event. In summary, the primary cause of exercise-associated hyponatremia is the excessive ingestion of water and sports drink, overwhelming the kidney's ability to excrete fluid, leading to dilution of the blood. Secondary causes include inappropriately elevated AVP, fluid absorption from the GI tract following exercise, sweating leading to sodium loss, inappropriately elevated ANP and BNP levels, and the inability to mobilize stored sodium in the bones. As such, risk factors for hyponatremia include longer races, frequent aid stations, certain medications, smaller individuals with inappropriate drinking, and the use of a drinking schedule. The following resources were particularly useful in the development of this video.